Acute pancreatitis. Acute pancreatitis. So, this is the most common inpatient principal gastrointestinal diagnosis, and the annual incidence ranges from 15 to 45 per 1 lakh person. So, acute pancreatitis incidence, it depends on distribution of etiologies. So, there are different etiologies responsible for acute pancreatitis. So, these are alcohol, gallstones, metabolic factors, drugs, and country of study. So, what is the etiology and pathogenesis? There are many causes of acute pancreatitis, and mechanisms by which each of these conditions trigger pancreatic inflammation. So, this has not been fully elucidated. So, what is the mechanism which triggers pancreatic inflammation is not fully elucidated. There are many causes of acute pancreatitis. So, of all these causes, gallstones and alcohol, so they account for 80 to 90% of identified cases of acute pancreatitis. So, which are most common? Gallstones and alcohol. They account for 80 to 90% of identified cases of acute pancreatitis. So, gallstones, so they continue to be the leading cause of acute pancreatitis in most series. So, in 30 to 60% of cases, so gallstones, they continue to be the leading cause of acute pancreatitis in most series. And the risk of acute pancreatitis in patients with gallstone less than 5 mm in diameter is fourfold greater. So, patients who are having gallstones which are less than 5 mm in diameter, so they have this, the risk is fourfold greater than that in patients with larger stones. So, then next most common causes, second most common cause is alcohol. So, the incidence of pancreatitis in alcoholics is surprisingly low. So, indicating that in addition to the amount of alcohol ingested, so not only alcohol but other factors also are responsible for pancreatic injury, such as cigarette smoking and genetic predisposition. So, apart from alcohol ingestion, so what are the other factors responsible for pancreatic injury? So, these are cigarette smoking and genetic predisposition. So, an acute pancreatitis occurs in 5 to 10% of patients following ERCP. However, this risk can be decreased with, so even in 5 to 10% of patients, acute pancreatitis occurs following ERCP, that is endoscopic retrograde cholangiopancreatography. However, this risk can be decreased with proper patient selection and use of a prophylactic pancreatic duct stent and or rectal NSIDs. So, how to decrease the risk? With proper patient selection and also the use of a prophylactic pancreatic duct stent and rectal NSIDs. So, what are the risk factors for post-ERCP pancreatitis? So, the risk factors for post-ERCP pancreatitis include minor papilla sphincterotomy, suspected sphincter of Oddi dysfunction, prior history of post-ERCP pancreatitis. So, what are the risk factors for post-ERCP pancreatitis? So, the risk factors for post-ERCP pancreatitis include minor papilla sphincterotomy, suspected sphincter of Oddi dysfunction, prior history of post-ERCP pancreatitis, age less than 60 years, more than 2 contrast injections into the pancreatic duct and endoscopist experience. So, what are the risk factors? Minor papilla sphincterotomy, suspected sphincter of Oddi dysfunction, prior history of post-ERCP, that is previously also post-ERCP pancreatitis, age less than 60 years and more than 2 contrast injections into the pancreatic duct and also the endoscopist experience. So, hypertriglyceridemia, so this is the cause of acute pancreatitis in 1 to 4% of cases. So what else can cause acute pancreatitis? Hypertriglyceridemia. So serum triglycerides are usually greater than 1000 milligrams per deciliter. So it is the cause of acute pancreatitis in 1 to 4% of cases, and triglyceride levels are usually greater than 1000 milligram per deciliter. And most patients with hypertriglyceridemic pancreatitis, they have undiagnosed or uncontrolled diabetes mellitus. So most patients having this hypertriglyceridemic pancreatitis, they have undiagnosed or uncontrolled diabetes mellitus. And an additional subset, they has an underlying derangement in lipid metabolism, probably unrelated to pancreatitis. So patients who have an underlying derangement in lipid metabolism, so they are prone to recurrent episodes of pancreatitis. So any factor, so whatever the factor may be, like alcohol or medications such as oral contraceptives, they cause an abrupt increase in serum triglycerides, and they potentially precipitate a bout of acute pancreatitis. So if there is any abrupt increase in the serum triglycerides by either alcohol or by the use of medicines such as oral contraceptives, they cause a bout of acute pancreatitis. And apart from this drugs and alcohol, a patient with a deficiency of apolipoprotein C2, they also have an increased incidence of pancreatitis. So patients with a deficiency of apolipoprotein C2. So what this apolipoprotein C2? So this activates lipoprotein lipase. So this is important in clearing chylomicrons from the bloodstream. So apolipoprotein C2 is there. So this apolipoprotein C2, this activates lipoprotein lipase. So what is the function of this lipoprotein lipase? So this is important in clearing the chylomicrons from the bloodstream. So if there is a deficiency of apolipoprotein C2, so this results in acute pancreatitis. Although frequently entertained, less than 2% of cases of acute pancreatitis are drug related. And so how drugs cause this pancreatitis? So this is caused either by a hypersensitivity reaction or by the generation of a toxic metabolite, although in some cases it is not clear which of these mechanisms is operative. So how drugs cause acute pancreatitis? So either it could be by a hypersensitivity reaction or by the generation of a toxic metabolite. Pathologically, acute pancreatitis ranges from interstitial pancreatitis. That is, in interstitial pancreatitis, the pancreas blood supply is maintained and it is generally self-limited. We have also acute pancreatitis, which is necrotizing pancreatitis. So in necrotizing pancreatitis, what will happen? The pancreas blood supply is interrupted. So pathologically, acute pancreatitis ranges from interstitial pancreatitis, wherein pancreas blood supply is maintained, to a necrotizing pancreatitis where pancreas blood supply is interrupted. And autodigestion, so this is a currently accepted pathogenic theory. So what is this pathogenic theory in acute pancreatitis? So this is a autodigestion. So this is a currently accepted pathogenic theory resulting when proteolytic enzymes. So what are these proteolytic enzymes? Trypsinogen, chymotrypsinogen, proelastase and lipolytic enzymes such as phospholipase A2, they are activated in the pancreas acinar cell compartment rather than the intestinal lumen. Instead of all these enzymes getting activated in the intestinal lumen, they are getting activated in the pancreas acinar cell compartment. So what are these different proteolytic enzymes? So these are trypsinogen, chymotrypsinogen, proelastase and lipolytic enzymes such as phospholipase A2. And a number of factors like endotoxins, exotoxins, viral infections, ischemia, oxidative stress, lysosomal calcium, direct trauma. So these are all believed to facilitate premature activation of trypsin. So why this premature activation is occurring? Because a number of factors, either endotoxins, exotoxins, viral infections, ischemia, oxidative stress, lysosomal calcium, direct trauma. So these are believed to facilitate premature activation of trypsin. So activated proteolytic enzymes, especially trypsin, they not only digest pancreatic and peripancreatic tissue, but they can also activate other enzymes such as elastase and phospholipase A2. So these activated proteolytic enzymes, especially the trypsin, so this is not only digesting the pancreatic and peripancreatic tissue, but this is also activating the other enzymes. So what are the other enzymes? So these are elastase and phospholipase A2. And spontaneous activation of trypsin also can occur, and this results in autodigestion. A number of factors apart from that, even there will be a spontaneous activation of trypsin which results in autodigestion. So what are the common causes of acute pancreatitis? The common causes include gallstones, including microlithiasis, that is less than 5 mm, alcohol, acute and chronic alcoholism, hypertriglyceridemia, and ERCP, especially after biliary manometry and idiopathic. So these are the common causes: gallstones, alcohol, hypertriglyceridemia, ERCP, and idiopathic. So activation of pancreatic enzymes in the pathogenesis of acute pancreatitis. So several studies have suggested that pancreatitis is a disease that evolves in 3 phases. So pancreatitis means it evolves in 3 phases. So the initial phase is characterized by, so what is the initial phase? Initially what will happen? So this is intrapancreatic digestive enzyme activation and acinar cell injury. First enzymes are activated and then they cause this acinar cell injury. So trypsin activation, so this trypsin, so this is enzyme which is important. So trypsin activation, it's intrapancreatic digestive enzyme activation. So this trypsin activation, how is it mediated? By lysosomal hydrolases such as cathepsin B that become co-localized with digestive enzymes in intracellular organelles. So trypsin, it is activation is mediated by lysosomal hydrolases. What are these lysosomal hydrolases? Such as cathepsin B. So these cathepsin B, it co-localized with digestive enzymes in the intracellular organelles. So it is believed that acinar cell injury is the consequence of trypsin activation. So why this acinar cell injury? Because of trypsin activation. And the second phase of pancreatitis, so this is the first phase is enzyme activation. The second phase of pancreatitis involves the activation, chemoattraction and sequestration of leukocytes and macrophages in the pancreas. So this results in an enhanced intrapancreatic inflammatory reaction. Then we have the second phase of pancreatitis. So in the second phase, what is happening is there is activation, there is chemoattraction, and there is sequestration of leukocytes and macrophages. So second phase is characterized by enhanced intrapancreatic inflammatory reaction because of the activation, attraction and sequestration of the leukocytes and macrophages. So first phase is enzyme activation, second phase is inflammatory reaction. So neutrophil depletion induced by prior administration of an anti-neutrophil serum, so it reduces severity of experimental. So neutrophils, so there is enough evidence to support that neutrophils, no, they can activate trypsinogen. So thus intrapancreatic acinar cell activation of trypsinogen, it could be a 2-step process. So the early step is trypsinogen activation. Early, this is neutrophil independent trypsinogen activation, and then we have a later neutrophil dependent phase. Initially an early neutrophil independent, and then we have a later neutrophil dependent phase. And then we have the third phase of pancreatitis. So in this third phase of pancreatitis, it is due to the effects of this activated proteolytic enzymes and cytokines released by the inflamed pancreas and distant organs. So all the enzymes are activated and cytokines are there released by the inflamed pancreas. They act on the distant organs. So first phase is enzyme activation, second phase is inflammatory reaction, neutrophil phase, and then the effects of these proteolytic enzymes and cytokines on the distant organs. So activated proteolytic enzymes, especially trypsin, so this enzyme is activated, so this not only digests pancreatic and peripancreatic tissue, but this also activates other enzymes such as elastase and phospholipase A2. So we have this activated proteolytic enzyme trypsin. So this is not only digesting the pancreatic and peripancreatic tissue, but it is also activating other enzymes such as elastase and phospholipase A2. So the active enzymes, cytokines, what will they do? They will digest the cellular membranes and then they will cause this proteolysis, edema, interstitial hemorrhage, vascular damage, coagulation necrosis, fat necrosis and cellular necrosis in the parenchyma. So what is the effect of these active enzymes? So these active enzymes, they are not only digesting the pancreatic and peripancreatic tissue, they are also activating other enzymes. So what are the other enzymes that are activated? So these are elastase and phospholipase A2. So these active enzymes and cytokines, they also then digest the cellular membranes and then they cause, because of this digestion, there will be a proteolysis, edema, interstitial hemorrhage, vascular damage, coagulation necrosis, fat necrosis, cellular necrosis in the parenchyma. So this cellular injury and death, because of the cell injury and because of the death of the cells, what will happen? This cellular injury, it causes liberation of the bradykinin peptides. It causes liberation of vasoactive substances and histamine. So these can produce vasodilation. This will cause increased vascular permeability and edema with profound effects on other organs. So cellular injury and death, so this results in the liberation of the bradykinin peptides, vasoactive substances and histamine. So this will produce vasodilation. This will cause increased vascular permeability and edema, and this has got profound effects on other organs. Then we have the systemic inflammatory response syndrome and acute respiratory distress syndrome, as well as multi-organ failure. So this is occurring as a result of this cascade of local and distant effects. So what is occurring? We have this systemic inflammatory response syndrome and acute respiratory distress syndrome, as well as multi-organ failure. So this occurs as a result of this cascade of the local and distant effects, and a number of genetic factors can increase the susceptibility and modify the severity of pancreatic injury. So all genetic factors, all these major genetic factors, what they do is they are mainly controlling the trypsin activity within the pancreatic acinar cell, because all these genetic factors, they are identified as candidate genes to link to mainly all these genes on trypsin control. So 6 genetic variants have been identified. What are these 6 genetic variants? Cationic trypsinogen gene, pancreatic secretory trypsin inhibitor SPINK1, the cystic fibrosis transmembrane conductance regulator, the chymotrypsin C gene, the calcium sensing receptor, and claudin-2. So what are the different genes? These are cationic trypsinogen gene PRSS1, pancreatic secretory trypsin inhibitor SPINK1, the cystic fibrosis transmembrane conductance regulator gene, the chymotrypsin C gene, the calcium sensing receptor, and claudin-2. So among these variants, only PRSS1 mutations are sufficient to precipitate acute pancreatitis in the absence of other risk factors, whereas the other variants are disease modifiers. So among these variants, only the PRSS1 mutations. So these are sufficient to precipitate acute pancreatitis in the absence of other risk factors, whereas the other variants are disease modifiers. So investigations of other genetic variants are currently underway and new genes will be added to the list in the future.